doctors don't
Yeah.
really bring that.
Okay. So we're going to finish up on sort of our overview of the female hormone primer. And we're going to talk a little bit about polycystic ovaries. Now, well, in the doctor summits, my good friend Felice Gersh had a whole 3-day or 5-day summit on polycystic ovaries with 50 speakers. So I'm sure they covered, like everything, um, and I'm a little miffed at her that she didn't call me to do something, but that we'll have to forgive her. Um, so so yes, a mystery series, but it's really not. Okay, and again, if we break it down, it's pretty obvious when patients come in, what the issue is, and it's not all that difficult to control, and there's no real cure for it, but we can control it pretty well with everything you already know, and with just a couple of added ingredients here. So again, this is written as a CME credit. So it's polycystic ovaries is the most common endocrine disorder in women of reproductive age. It affects anywhere from 4 to 10% of the women in the US and accounts for 75% of the women with amenorrhea. So officially it's three things. It's amenorrhea or oligomenorrhea, excess androgen, and cysts on the ovaries. And depending on who you read, it has to be at least 8, and some literature says 10, or sorry, excuse me, 12. So that's what it is, polycystic ovaries. So it's androgens, amenorrhea or oligomenorrhea, and multiple cysts. So when you get an ovulation, you get an increase in LH and a decrease in FSH. The LH increases testosterone and androstenedione, and then you get the aromatization from testosterone aromatizes to estrogen. So then you get the non-existent estrogen dominance. Thank you, Dr. Rosier. and is he the one who says that's non-existent? Is that part of his shtick?
Well, that what is non-existent, sir? I'm sorry.
That estrogen dominance does not exist?
Yeah, he's one of the notorious ones. Yes.
Right. All right. So I don't know how they explain these things then if it doesn't exist. Um, and so then you get estrogen excess, which you should know what that is now,
Yeah.
or progesterone deficiency. Did they call it that? I'm gonna
Yeah.
I'm gonna have to go back and listen to one of them. I can only get about halfway through, and the sarcasm just kind of gets to me. I stopped listening, with all the sarcastic remarks. Um, so, progesterone deficiency, is that it then? Is that what they call it? I mean, it's a hormone imbalance. It's got to be something.
Yeah. Well, it's yeah, progesterone imbalance. I think that's the best that they can come
All
to
right.
that description.
All right. So here you go. Oligo ovulation, anovulation, clinical signs of estrogen or androgen excess, and polycystic ovaries. In this paper, it's greater than 12 follicles, and they have to be 2 to 9 millimeters or a volume of greater than 10 milliliters. Okay. Symptoms typically are obesity and the inability to lose weight, high hip to weight ratio greater than 0.85, and BMI greater than 30. Oily skin and acne, alopecia, depression, irritability, tension, acrochron, how do I pronounce that? Do you know how to pronounce that? Acrochronosis, skin tags, acanthus nigrans, irregular or absent menses, infertility, insulin resistance, blood sugar abnormalities, hypoglycemia, and hypertension. Okay, so before we go any further, are these symptoms here logical, or are they just disparate and they're different symptoms and we have to go chase them?
No, I think they're fairly logical. Yes, sir.
Okay. All right. So it shouldn't be all that difficult to come up with a remedy plan, right? We take care of the excess androgen. We take care of the excess estrogens. We can reorient the menstrual cycle, right?
Yes, sir.
And the other fallout that's not in the official diagnosis, but which is pretty prominent, is that you get blood sugar abnormalities.
Uh,
And so the polycystic ovary syndrome, again, is three things, but it also includes glucose or insulin resistance. So you can have high testosterone, blood sugar abnormalities, normal ovaries, and not cystic, and it's also considered polycystic ovary syndrome. And you can call it whatever you want, but if you have to do, coding for insurance, I don't know if you guys do insurance or not, but if you have to do coding, then that's you're in the realm of polycystic ovary syndrome with that. Okay. Just a reminder, you've seen this picture before. Estrogen metabolism, testosterone. Again, conjugated in the liver. It comes from cholesterol. Converts via the star enzyme to pregnenolone, which will convert to DHEA to androstenedione, and depending on which pathway it goes, we're looking at testosterone. Correct? Testosterone is metabolized by two enzymes, 5-alpha reductase and aromatase. The 5-alpha reductase converts testosterone to dihydrotestosterone, and the dihydrotestosterone, the consensus is the sort of super testosterone, and that's where you get the male characteristics from. It affects the skin, liver, and prostate, and it deals with facial hair, body hair, prostate cell growth, and acne. The aromatase converts testosterone into estradiol, and that is affected mostly in the brain, fat, and liver. And this deals with bone structure, cholesterol, especially HDL cholesterol, cognitive function, breast proliferation. And testosterone deals with spermatogenesis in males, and the sexual function in females. Also muscle mass and bone formation. So that's pretty much, sort of a synopsis of testosterone metabolism. Polycystic ovaries, here are the hormonal effects. And again, hyperandrogenism, which results in all these things you see on the right there. Acne, alopecia, hirsutism, and alopecia, which seems like a contradiction in terms, but remember the DHT is prominent in the scalp. Below the eyebrows, it actually enhances hair growth. Chronic anovulation, you got abnormal hormone receptors, poor libido and sexual issues, pregnancy complications, and infertility. So those are the sort of the outcroppings of what we're seeing. You also get in the metabolic effects. You get hyperinsulinemia, impaired glucose tolerance, dyslipidemia, visceral obesity, overweight, obesity, insulin resistance, fatty liver, endothelial dysfunction, and hypertension. So just looking at that, do you think the GLP-1s would be effective in this scenario?
Absolutely. Yes, sir.
Yeah. Okay. So, again, these were put together well before that. So, we'll have to look at that. In your new information from A4M, did they mention that at all with this?
No, they have not. No, sir.
Okay.
No.
All right. So that's something I think that we'll probably need to add. Okay.
Yeah.
You can make a whole career out of just polycystic ovaries. He said, I'm the polycystic ovary specialist. so, right. I think you can, between that and thyroid disease, you can make a whole career out of just being just do those two. Right.
Absolutely. What is your, I guess probably the biggest conundrum amongst primary care providers you're in a unique situation. I mean, you're boarded in family medicine, resident trained in family medicine and OBGYN, so you have such a unique experience or perspective. But just the average run of the mill primary care guys, really struggle with. Well, I have a patient here. She is clearly she has polycystic ovarian syndrome, but she has symptoms of androgen deficiency. What the heck am I going to do? I can't give her any androgens because she's already making way too many. But how do I deal with these symptoms that would seem to be responsive to testosterone therapy? When at the same time I can't give her testosterone. So I think that's
No, there's no reason. I mean, if her testosterone levels are low, there's no reason you can't. Okay. I mean, does she have symptoms of high testosterone with low testosterone levels? Is that what you're telling me?
yeah. So these patients that have decreased libido, stubborn weight gain, brain fog. They have reduced muscularity, delayed muscle recovery, but yet they have high levels of androgens because of the pathophysiology of
Yeah,
PCOS.
well, I think that some of those first symptoms you described are actually the estrogen, the non-existent estrogen excess from,
Yes.
right? Yeah, that's from your aromatization, right? That would be a visceral fat and sort of muscle, softening. What else? Whatever else you told me. Doesn't that sound like estrogen excess that doesn't exist?
That could be. Yes, sir.
Yeah,
Absolutely. So
yeah.
it does exist.
Yeah,
Voila.
yeah, so I mean, I'm sure you by now you tell these people for this not instant gratification. This is going to take some time. When I went through the class, they told I remember Pam Smith telling us you have to tell the patients it's going to take 6 months to 2 years to fix everything. And I remember saying to myself, nobody's going to wait 2 years. Um, but 3 to 6 months is pretty reasonable, and we can get most of our patients on a good pathway, in that time. So that's what I tell them. This is going to take at least 3 to 6 months before you're gonna notice a difference, and you have to sort of hang in there with us. And things like hair loss, and we'll talk about that if you want a little bit. Do we do hair at all?
Sorry.
Did we ever do hair?
No, we have not. But the two big
Okay.
things as a matter of fact, I wanted to ask you. I'm so glad that you mentioned this because just last 2 weeks, I've had the group has about 9 or 10 patients calling in complaining of acne and hair loss on testosterone and what to do about that, other than messing with their testosterone dose. So
Right. Yeah. Um, so again, testosterone goes to dihydrotestosterone, so you need to take a look at that. Um, but what'll and I don't remember why I mentioned hair loss in the first place. Do you remember where I was?
no, you ask if we did hair.
Yeah, yeah, I know. But before that, there was a reason for it. Um,
Is it related to PCOS?
yeah, yeah. Oh, yeah. Again, you're going to get hair loss with excess testosterone. You're going to get a hair loss with excess estrogen. And where's the hair coming in? Oh, I remember now. Okay, so at first you want to see where's the hair, where are they losing the hair? If it's behind the hairline, sort of, you take your palm and put it on the top of your head, if that's where it is, behind the hairline, in the front, that's an estrogen excess hair loss. If it's that sort of male pattern baldness, and in females, the hair they start losing it in the part first, and then the part starts to widen. And that's testosterone hair loss. So you need to look to see where the hair loss is. But and now I remember what it was. Okay, so when you get hair loss, and then we you want to do something about it. Probably for the first month, 4 weeks or so, you're going to get more hair loss. So what happens is that when you start sending nutrients to the scalp or manipulating the scalp or doing something to the scalp, um, dying and dead hairs will come out first. And so for the first 4 weeks, it's going to look like that they're basically shedding, the dead hair, and killing off the dying hair follicles, and it'll look like it's getting worse. So you need to tell them that. Okay. They have to get through the first 4 weeks. The next stage is hair. You stop losing hair. And so it'll start looking, the hair that's there will continue to grow. So it will look like the hair is getting, getting thicker. But what it is that the hair loss has stopped. It takes about 4 to 6 months for you start to get hair regrowth. And it's usually not very complete. And if we go through it, so I have a whole hair lecture, and it goes through a lot of the products, and it'll tell you which ones are how much hair regrowth you'll get from each one of the ingredients. So we can do that at some point shortly too. Okay. But that's kind of the general. So you have to know the sort of the life cycle of a hair follicle, and then it makes sense. Okay. So a live hair will live for about 2 to 6 years. Then it becomes dormant. And when it becomes dormant, that's when it sort of crinkles and starts to die off. And that takes about 4 weeks. That's where you get the hair shedding. So and that's what that happens. And so again, it'll look like it's getting worse before and then a lot of patients, if you don't tell them this, they'll exactly at the 4-week mark, they'll call you and say, well, you told me to do this, that, and the other thing, and it got worse, so I stopped. Right. And so they stop right at the point where when the healing begins. So keep that in mind. Okay.
Yes, sir.
Got that? Okay. So that's hair loss. I have a whole thing on hair loss. If we can do that.
Please. Yes, sir. I guess also the treatment plans, I guess also would apply to acne as well.
Yeah. Mm-hmm. Yeah, well, we're going to look at a little bit of that right now. So, so you get abdominal fat is altered, insulin resistance, immune cell reactivity, impaired circadian rhythm, and then of course our friend the microbiome. Okay, so you need to look at all of those things. So for insulin resistance, you get decreased insulin, you increase sex hormone binding globulin. That's wrong. You get insulin will decrease sex hormone binding globulin and which increases circulating testosterone. Okay, this right?
Yes, sir.
Insulin plus LH. Remember LH. Remember that my little mnemonic to remember stimulates the Leydig cells, which luteinizing hormone stimulates the Leydig cells. And that's where you get a testosterone generated from. FSH in males, S is for sperm, which is the Sertoli cells, which stimulates sperm production. We don't have to worry about that in ladies, but just remember the LH will increase the testosterone. Okay. You get the decrease in the 2-hydroxy hydroxylation and 17-alpha oxidation. So you go down the estrone pathway. Increased estrogen is due to peripheral aromatization of androstenedione, and that's where you end up with estrogen dominant. So you get excess testosterone, aromatizes to estrogen. Excess testosterone, you're going to end up with excess estrogen. That's what happens in guys, and we argued about that last week, right? The jury's still out on that. And did you talk about that podcast that you did with Jay Campbell? Was that back in September?
Yeah, it was a while ago. It was back in September.
Because he just advertised. I mean, as I said last week when I sent it, mentioned it, that that's when I first saw it. And I think he said it was September 14th. So that was the FDA cut off that was before the FDA cut off the peptides.
Right before, yes, sir, absolutely. Yeah.
So okay, so polycystic ovaries, you're going to get an increase in testosterone, androstenedione, insulin levels, insulin resistance, an increase in FSH to LH ratio, lipids, blood pressure, DHEA levels, estrone, IGF-1. So they're all, it's all pretty, it's a pretty nice pattern. And back when in our gynecology days, we didn't recognize these things. I mean, we weren't taught them, or maybe I just wasn't smart enough to realize them. But you do hormone optimization for a while, and hopefully you're starting to recognize these patterns, right? So I love that I had a student from the Arkansas College of Osteopathic Medicine with me, and I had a student from UNR at the same time. And we had a lady come in with the polycystic ovary, and so I handed them the lab values, and the guy from Arkansas who had been with me for a while looked at it, and he knew what it was right away. And the UNR guy who that was his first day there, and he's struggling to explain this and that and the other thing. And I said, he looked at Kevin, and the guy's name was Kevin. He looks at Kevin and says, "How did you know this so fast?" He says, "Well, hang around here, you'll get it." So, okay. So, and again, nothing new for you here. You should know this by now. Testosterone excess, right? Acne, deepening voice, hair loss, or unwanted hair growth. Remember, the hair loss is from the eyebrows up. It's on the scalp with excess testosterone. And it's below the eyebrows, you get hair growth, right? Because there's a difference in the DHT, right, in the tissues, right? By the way, for a while there, we were measuring DHT in serum, and I didn't really find that it correlated with what we found clinically. So I don't know if you've ever done that. I kind of, if I get it, fine, but I don't really order it myself. They kind of discount it. You really need like scalp. You need tissue levels to give you anything meaningful. So,
of DHT.
Yeah. Have you found it to be useful at all?
So I mean, if I have a patient that complains, of accelerated hair loss, on testosterone, then I'll get a serum DHT level. And it usually comports with with their complaints.
Yeah. Yeah. All right. Maybe I should clarify it. Like as a predictive value, I don't think it's been very helpful. So. Okay. So, and so, testosterone, anxiety, depression, fatigue, this is too much, right? Sugar and salt cravings, those are cortisol issues. And again, with polycystic ovaries, you're going to get increased inflammation, facial hair, insulin resistance, weight gain, increased risk of heart disease, irritability, anger, moodiness. I don't know. I don't see it that much with testosterone. I know they write about it all the time. What is it? Testo rage, or what do they call it? But I don't really see it all that often. So hair loss, yeah. And remember, if the hair loss is in the part, since we're talking about women, that's a testosterone hair loss. If the hair loss is behind the hairline, if you put your palm right on the top of your head, palm facing, palm down, your arm facing your face behind the hairline, that's estrogen loss. Okay. I got this from Felice Gersh, the microbiome diet, and again, nothing new. Complex carbohydrates, healthy fats, high fiber diet, alkaline diet works nicely here. Probiotics, green leafy vegetables, limit protein, especially animal protein, to about 12%, and any sugar, alcohol, alcohol, sugar, dairy, white flour, white sugar, dairy, is probably no good. Eggs are probably plus or minus. Some patients are sensitive to them, some are not. You can do like an elimination test if you don't want to do a food sensitive, a blood test, a food sensitivity test, and food intolerances. So again, these are fairly common. You need to look at the microbiome. So what test are you using for that now? Using GIFX or?
Yeah, either GIFX or a GI map.
Okay. So the Megasport people have a test out now too. So I might try that one.
Oh,
We had her on Wednesday or on our Tuesday night a couple of weeks ago, and then there was a integrative dermatology conference in Reno that I didn't even know about. She showed up at my office as just as a drug rep, and she says, "Oh, we're at the conference this weekend." I didn't even know it was in Reno. I didn't even know it was there. So we went over there, and
dermatology. That's
yeah,
wow.
next year I think it's in Dallas actually. So
Really?
yeah. Yeah, it was in Reno. It was here for it was 4 days here. I didn't even know about it. Didn't even know it was here. But I did go over when she told me. So she was on, and they have a lot of information. The mega sport people. So we're gonna have to look at the microbiome a little bit more closely. So here's a food chart for acid and alkaline foods, and pretty much everything on the right. And again, nothing new. Everything on the left: artificial sweeteners, alcohol, processed foods, white flour, white sugar, dairy. Those are always my stay away from. Any type of meats are acidic. Shellfish, lesser so, and then the green leafy vegetables are the best here. So here's a chart here. I mean, if you want to get a copy of it and just, give it to your patients, that's fine. So here's a sort of a sample of non prescription sort of improvement of everything that we get. So calcium D-glucarate is kind of interesting. It's I just we had used it for patients with what's the one with that high calprotectin? This is I'm turning 70 in 2 months, and my brain's not, and as you can tell from this morning, it's not working the way it used to. It's ulcerative colitis, is that it?
What about ulcerative colitis, sir? I'm
Is
sorry.
that calprotectin? If calprotectin's high, that's ulcerative colitis, is that?
Well, I heard that that calprotectin that was somebody from IFM. I heard a lecture from a presenter from IFM that said that calprotectin in the presence of one other lab parameter, that if they are negative, that it kind of is almost supplanting the need for an endoscopic evaluation of the GI tract in terms of screening. But the probability of the risk of colon cancer is profoundly low. So I gotta go. I wish I would, but anyway, yeah, a big marker for inflammatory bowel disease.
Right, exactly. Okay, so calcium D-glucarate actually has has estrogen lowering properties to it, and I think it's 250 milligrams twice a day. Will on average within 6 weeks decrease estradiol levels by about 20%.
Really? And
Yeah.
now, what is your impression of how strong DIM is in doing that, in decreasing estrogen?
And I think it depends on the quality of it.
Like if it's bioresponsive DIM, the good stuff, the one that's been studied, does it work as well as calcium D-glucarate? Can you give them both?
Well, this is coming right. This chart's coming from Felice Gersh that she does. So
She does. She gives them both. Okay.
she gives them both, right? Um, so, um, so we started going with this with calcium D-glucarate. Doesn't we don't not really seeing any side effects from it that and it gives them some GI comfort also. So if they're if they have any GI symptoms, the calcium D-glucarate seems to calm that down also. So so this is new. This is new for me anyway. So N-acetylcysteine You need 1,800 milligrams. I know she only has 900 here, but you need 1,800 milligrams for it to be effective. Most of the supplements come at 600, so you'll need 3 a day. We have one from, I think it's New Medica is a 900, so 2 a day. So I would do 2 a day here. Okay. The probiotics, we like the spore-based ones. So Megaspore or Orthomolecular makes one that's a little less expensive. That's pretty much the same thing. Prebiotics and L-glutamine. So I can never pronounce that name. Arabino something, Arabino Mac Sactin, something like that.
Have no black hands.
Yeah, that's it. You're gonna have to be my. I'll get it started. You'll have to finish it for me. My brain's just not working here today. I don't know what the hell is going on here. So, fish oil. Fish oil, EPA, DHA, 1 gram, and they tell me it's the DHA that's the main ingredient. For the polycystic ovaries.
Oh, they what's forgive me, I didn't mean I don't want to. This is related to the fish oil. I saw in a pharmacy, in a compounding pharmacy, I saw a bottle of Designs for Health, essential fatty acid, fish oil supplement. But it was a new product that they had, but it said now with DMA. What is DMA?
I have no idea.
So it must be something.
All right. I'm turning 70. You're gonna keep me young, right? So myo-inositol, I'm going to give you a little bit more information on that. This really is great for restarting their menstrual cycle. So it's myo-inositol. We're going to talk about this a little bit. And again, we're okay to use brand names here. There's one called Ovasitol. And if you go on their website and sign up as a practitioner, patients can get a discount on it. And this stuff is one of the game changers for polycystic ovaries. So you really want to make sure that you look into that. I'm going to give you I got a whole slide or two on that coming right up. So just hold your questions on that. Remember berberine, we use that for, as insulin resistance. And I like the New Medica one. It's 400 milligrams for weight maintenance or even a little bit of loss. 400 milligrams. We do 2 in the morning, two at night. It has gynostemma in it, which is the AMPK activator. So it's a combination. That's New Medica. There's also one called Alamax from Zymogen, which is berberine and chromium. No, that's berberine and alpha lipoic acid. They also have the berberine and chromium, which is a sort of a double whammy for insulin resistance, is called berberine, and it's berberine in C2, but it's berberine in IN, new word, C, SEA, and the number 2. That's what they labeled it. So
Berberine.
Yeah. Berberine in IN, berberine, new word, IN, new word, SEA, and the number 2.
And what's special about that compound, sir?
It's berberine and chromium.
Oh, berberine and chromium.
Okay. Alamax is berberine and alpha lipoic acid.
Yeah.
So we use that for peripheral neuropathy. And make sure if you're using anything for peripheral neuropathy, if you're going to use the alpha lipoic acid, it has to be at least 300 milligrams twice a day. And, there's a mixed bag on that. If it's pretty mild and it's pretty new, you may get somewhere. I mean, if it's, if their hands and feet have been numb for 20 years, I don't think it's going to do a whole lot. So N-acetylcysteine, is your liver detox agent. And again, 900 milligrams twice a day is probably adequate. Vitamin D, this again, this is from Felice Gersh. We titrate it up to 50 to 80. And you know how to do that now, right? You know all my tricks, right? You remember how to do that?
Increasing what from 50 to 80, sir? I'm sorry.
Vitamin D.
Um, could you remind me real quick? I'm sorry.
Yeah. So for every 1,000 units, the vitamin D level will go up by about 8 points.
Okay.
So the big bottle at Costco is a 2,000 unit bottle. So 2 times 8 is 16. So they show up with a vitamin D level pretty common here. Now is in the low 30s, 32, 35. So if they show up at here, let's say 35. If we tell them to go get the bottle, the Costco one, and those sometimes work nicely and sometimes they don't work at all. So 2 times 8, remember it's 1,000, you get 8 points. So 2 times 8 is 16 and 35. That'll get us to 51, which is the bottom of our 50 to 80 range. If we did 4,000, 4 times 8 is 32 and 35 is 67. Remember, our midpoint is 65. So that's about the right amount. We always use vitamin D at bedtime. It's a bit sedating. It helps other hormones, including cortisol and growth hormone, function better. And it's good for your skin. It's good for your immune system. You know the whole 9 yards on the vitamin D, right?
What is your feelings, Dr. Clearfield, about the importance of giving K2 with vitamin D? I hear this now talked a lot in the functional medicine space that no longer should you give vitamin D at higher doses without K2 because it causes calcium deposition in places where it shouldn't be, like coronary arteries and et cetera. So you always have to give a
Yeah. You're right. You're right. So again, you can get it either as a prescription or we get it from Zymogen. They have a 50,000 unit once a week one with K2 in it. And it's pretty inexpensive. I think it's about $12 for 30 of them, and it's once a week. So it's pretty cheap. Yeah, K2 wasn't something on the radar back when all this was sinking in. So I have to. That's one of the ones I have to go back and revisit. But I hear the same thing you do, and a lot of patients ask for it. So we've been getting it, but I'm not all that versed on using the K2 with the D. But I'll get there. That'll be your homework assignment.
Okay, sounds good.
Okay. Fish oil, and then as you know here, these anti-inflammatories. So Mike Beamer, you know him? He was at Apex till the guy died. He's working with Wells Pharmacy now. He's come up with a formula, an anti-aging formula that has 30 ingredients in it. So it's 2 capsules twice a day, and it actually has all of these in it.
Really?
Yeah. Mm-hmm. And more. So they're going to be rolling it out they're going to have a booth, and they're rolling it out at A4M. So
it's targeted for PCOS patients primarily.
No, it's just basically this is just about every one of the anti-aging agents that we use, anti-inflammatory, anti-aging agents that we use. They put it all in. Well, he said he couldn't get it all in one capsule, it's 2 capsules twice a day. When we're done, I have the flyer for it. When we're done, I'll find it. I'll email it to you. Okay.
It's by Apex Energetics.
Well, no, he was at AMEX Pharmacy in Florida, and the owner died, and all of a sudden he's out of it. He's been there for 30 years, and all of a sudden he's out of a job. So he's moved over to Wells Pharmacy for now, and he's trying to I think he's trying to buy the company from the estate. So, I mean, he was the the pharmacist there. He was the guy we would get the he was Halas's friend. He's the guy we got the ivermectin from, and
Okay.
did all that, during the shutdown, and they'd make it into 30 milligram lozenges if you wanted to. So, and then, they didn't report you to the medical board like Walgreens did.
Wow. Unbelievable.
Yeah. So I just got an email, by the way, from Eric Stoller, who's he says, we have a venue to do a seminar after the expo on Saturday. And you want to know if I'm available. We have a studio and we will also video. So,
Wow.
so I just got that. So, okay. So here's here's a little, treatment protocol. Again, polycystic ovaries. The medical doctor, and I'm sure you've heard this, because by the time they get to us, they've been to three gynecologists and 2 endocrinologists, and they'll give them first thing they'll give them is metformin. And our patients, when they call and make an appointment, I've heard this more than once, say, if he's going to give me metformin, I'm not even going to make an appointment. I don't know what it is about metformin that these ladies, they hate it. At least the ones that we get to. So the medical doctor treatment is metformin and spironolactone.
Yeah.
And quite frankly, spironolactone works pretty well for the excess androgen symptoms. It's a bit of a diuretic, as you know. It's a potassium-sparing diuretic, and it does work quite nicely. I don't have so much problems with that, but for some reason, metformin, I think there's some GI issues with it. They already have bad stomachs, so I think that's what the issue is. So this is kind of the sort of the standard medical doctor thing. So spironolactone, cimetidine. I've never used. Have you ever used that? Tagamet.
Oh.
Ketoconazole, which is an antifungal agent. I'm not sure what that's in there for. Ketoconazole shampoo, 2% shampoo, is usually part of our hair regrowth program. It might be that. Lupronide, I'm not comfortable using those. I don't use that. Finasteride, again, for hair issues. Progesterone, we do use that a lot. Low glycemic index diet. Estrogenic polycystic or estrogenic blood birth control pills. I never write for birth control pills. I don't know if you do or not. Do you write for birth control pills?
Stay away from them if at all possible.
Yeah, we try to. HCG, again, I'm not so sure about that. HCG raises testosterone levels, so I'm not sure why that's in there. Ovarian wedge resection, we used to do those, and laparoscopic drilling. We would sort of like punch holes in the ovaries. So I'm not sure exactly what that did, but yeah.
Laparoscopic drilling.
Okay. Again, here's another list of, and again, so you got anti-inflammatories, N-acetylcysteine, black cohosh and chasteberry is, for sort of PMS symptoms, saw palmetto, green tea extract, those will lower testosterone levels a little bit, spearmint tea, and then that myochiroinositol. For insulin resistance, lentils, chickpeas, broccoli, fenugreek. I wrote a book in 1992 when it was a Chinese medical diet, and I actually wrote about fenugreek seed to lower insulin and blood sugars, and it was dated 1992. So it's something, again, if something else isn't working, cinnamon, Gymnea sylvestri, vanadium, those are all the A4M go-tos. There's a fourth one, Gymnea, chromium, right? Cinnamon, chromium, Gymnea sylvestri, and vanadium. And that's all the components. Again, Zymogen, they have a compound that's called Syndrome X, CINNDROME, and capital X. And that's those ingredients. Numedica has one called Synergy, CINNERGY, has the same thing. So, Okay, so acne again. So acne, you want to reduce the testosterone. So saw palmetto, metformin if they'll allow it, spironolactone, spearmint tea. So we like spearmint tea a lot. If you remember, I probably talked about it. You need 100 milligrams of spearmint. So it's a double bag if you're using Lipton, and probably most other teas. So you need two tea bags in 1 cup of water. And this works pretty well if they use it. 4 to 6 weeks, you can get up to a 20% decrease in testosterone levels in the total and the free.
Really? Okay.
So, 20%, their testosterone levels are 50, it'll go down to 40. That's where we want it to be.
Sure.
So the real problem with it is they get kind of lazy, and it gets a little bit old. They can use peppermint. It doesn't work quite as well, but they can use peppermint also. But it gets, every day spearmint tea, a double bag, which is pretty strong. It gets a little bit old. I think that's what the real problem is with it. So I've not experimented with like pills or anything like that, so I don't really know. Hair loss. Again, so reduce the testosterone, of course, increase estrogen and progesterone, finasteride, platelet-rich plasma. We have a bunch of other creams, a melatonin 1% cream. We've had some success with that. We do a genetic test, come from GX Sciences, and they'll give you an exact formula for each patient, individualized.
Have you used this with anybody yet, sir?
Oh yeah, we've been using it for years.
Wow. And how does it, I mean, it works well?
Yeah. And they'll give you a printout. They just condensed it. They used to give you 2 printouts that were 30 pages each, and they go through each gene, and each SNP. And I mean, it was way too much information for me. So basically the patients just want the bottom line. So at the end of it, I can, we're almost done here. If you want, I can pull one up and show you what it looks like.
Oh, yes, sir.
Okay. So
do you find that we talked about it a little bit at Viking, and Sam was looking into it, trying to, because of course his bottom line is how can the practice benefit financially? We certainly would have the patients, but do you find that you make a fair amount of money actually ordering the test yourself instead of
they've combined this now into one thing, but this is the older one. So this is the report, and Joel's okay with me showing his name. So so I'm gonna have to do something, I guess, to that video. I guess some names showed up, huh? I'm gonna have to cut that out somehow. So they give you, here's generic, what's relevant. Here's male pattern hair loss. Here's female pattern hair loss. Remember I told you it starts in a part, goes there. There's 3 types of hair loss. And again, so we'll do this as a separate talk, and we'll go through everything. And there's a lot of technicalities here. These are the things that they look at. So the inflammation, immune modulators, any type of scalp fungus, prostaglandins will be circulation, different minerals, hair strengthening, androgens, vitamins. So each one of these categories, and they look at SNPs for all of them. And so there's, like I said, there's a lot of technical information here. So green means will have a positive influence on that person. Yellow means sort of neutral, and the pink or red is negative. So we're looking for the greens. So as you can see here, they go through each one of these SNPs, and they'll give you they tell you what it is and what it's regulated. And if you want, I'll send you one of these. I'll send you this.
yes.
As you can see, it's pretty extensive, to go through all of this. Fortunately, I'll give you a summary here. Okay. And so remember, Joel's got the discoid lupus, so you would think the anti-inflammatories would work, but apparently not. So there's no way for you to sort of know, accurately know, what to use if you don't do it in this sort of fashion. I mean, you can do generalized things. So minoxidil, as you know, is the cream that's Rogaine. And so then they tell you what each one SNP is and why it's important. And, it's like TMI as far as I'm concerned. Look at all of this, right? And if you get through all of this, I mean, you're gonna know more than 90% of genetic people. So that's the sort of the general overall. And then the second, now this is an older one. They've sort of streamlined this some, so you only get one report now, and you get the bottom line right up front. So, but here they go through those SNPs again. But this is where the rubber meets the road. So here's the formula for Joel. Okay. So cetrizine, that's Zyrtec. So that's it's a allergy. It's an anti-inflammatory. Spironolactone, blocks testosterone side effects, and adenosine is a nutrient. And so you put this in 100 cc's of tricosol. Anazao will make this for you. Anazao actually came up with this tricosol sort of base. Have them use 1 or 2 milliliters at bedtime. We made a video with for scalp massage. So scalp massage works really well, but you have to be pretty vigilant with it. You have to do at least 10 minutes twice a day for 6 to 8 months, which is a lot for it to have any type of effect. And then we use a derma roller. So, the little wheel with the little needles. You have to make sure it's less than 1.5 millimeters or less, because the hair follicles are at 2 millimeters. You don't want to, break them up. And so we'll use this formula every night for 6 months minimum. Once a week, we'll have them use the derma roller first, and then put the cream one, and scalp massage. And there's some devices you can get. There's a thing that's almost like a blood pressure cuff that wraps around your head, and you pump it up, and the idea is to increase blood flow to the scalp. I will say that when we were doing the video, we were practicing for the video for the scalp massage. Man, my thinking and energy, exploded. I mean, I was sleeping 3 hours a night, and I was getting stuff done that like nobody's business. I mean, it really increases your brain power.
I mean,
I have a video that I made on it, so I can send you that link if you want.
sir, that'd be great.
Yeah, it was supposed to be a 15-minute video, and it ended up being 45 minutes. And you didn't meet him when he was here. Jeffrey Munson's my dance teacher. Actually, he's my foil there. So did you ever see any of the other videos that we made from like long ago, like 5 years ago?
No.
Okay, so he's in them with me. So I wanted to make some videos, and I was terrible at it. I mean, just awful. And I had the script and all, and it just wouldn't work. And then he said Joel was filming it. He was filming it, and then one day he says, "Here, let's just talk." And he got in front of the camera with me, and you go on our YouTube channel and look at some of them. Some of them are hysterical, and there's pretty good information on them too. So, one of them has we had one called "Slow Your Roll." It's acupuncture. How to retain your energy during sexual activity, so that you prolong your time, your game time. Had 38,000 views without any advertising on it. That's my best video.
It's an acupuncture trick or
It's an well, we do acupressure, so I show you where the points are, where to squeeze, and it's just on the arm and the leg. It's not anything, there's nothing's exposed at all.
wow. Like people reporting that they were getting benefit from that.
Oh yeah. Yeah, it's called go on. It's a look on Clearfield Medical Groups, my YouTube channel. I have a YouTube channel. I think I have 1,100 subscribers too. And again, I don't even know how most of those videos got there. I didn't put them there. So it's called Slow Your Roll. It's called Slow Your Roll. Type that in, you'll see it. It's pretty funny. And that one's not too long. That's maybe 7 or 8 minutes. Well,
awesome. Yeah, that's great. I'll look at it for sure.
okay, and then they also put together they I think they have this outfit has their own like compounding pharmacy. I think they want you to use their, I don't. So if you look at this formula, they have an oral formula too. So it's zinc, cysteine, and lysine. So if you make that into one capsule, it's going to cost 50 to 80 bucks a month, right? But you can buy all 3 of these things over at the Sam's Club for pretty inexpensive separately. So that's what I usually tell the patients to do. So, you can get lysine and zinc and cysteine for almost nothing. So you don't have to pay. I think I wrote this formula up. Somebody that took it to a compounding pharmacy, they wanted $100 a month for it. So it's kind of a waste of money. So that's what you get. You get the formula. And then you get a topical, you get an oral, and I think there's a backup sometimes too. Yeah, so here's a backup. So, and it's specifically for him. You only have to do it once because it won't change. And so we have a lot of good success with this. But again, once you start using this, the hair is going to come out. You got to tell the patients your hair is going to come out for a month. Then the hair will stop coming, then you'll stop losing hair, then you'll gain it. And if they gain with these kind of formulas, you can gain back about 40 to 50% of the hair loss. But again, the hair follicles have to be, they can be dying, but once they're dead, male pattern hair loss, once they're dead, they're gone, then they're gone. So like you there, you'd have to do something else. Okay, if you got it in your late teens or early 20s, you might have been able to save. And again, I mean, this is sort of a lifetime thing, and it's a long-term thing. So
this was all on purpose, sir. When I joined the SWAT team, this was part of the initiation.
Okay. So
Yeah.
do you have hair or no?
Oh yeah.
Oh, you have hair. Okay, so it wouldn't recognize you now with it, right? All right, let's wrap this up here. Okay. So again, acne is a imbalance between the estrogens and the androgens. You want to increase your estrogens, decrease your androgens. Excess hair growth, pretty much the same thing. And to induce an ovulation is the myo-inositol. So this stuff is really great. I came to this late. It improves insulin resistance and excess androgen. Induces ovulation in polycystic ovarian women. Restores ovulation. There's a study here that says it improves oocyte quality and again, use a good quality one. Okay, the one we like is called Ovasitol. I'll show it to you here in a second. Here are all the remedies for testosterone excess, too much testosterone. And again, the patients come to you and say they hate the metformin. Spearmint tea, we talked about. Black cohosh and chasteberry are usually combinations. Saw palmetto, resveratrol, and white peony is a Chinese herb. And then some specialty things. So DGL licorice, do you ever use that for GERD?
Yes, I have. Yes.
Yeah. So again, it'll reduce testosterone. And this came from our autism lecture. So the autistic kids with their behaviors. So you're going to find autistic kids, if you ever deal with them, they have high testosterone levels, especially for their age. And so agitation, anxiety, irritability, hirsutism, so deglutinated licorice, and that comes as a chewable, N-acetylcysteine, and again, fish oil, omega-3 fatty acids. So that's our polycystic ovary kind of deal. Again, so here's Julie. Remember Julie? So diet, white flour, white sugar, dairy, moderate caffeine and alcohol. For the estrogen excess that doesn't exist, micronized progesterone. Remember, the pills are more potent than the cream. 100 to 200 milligrams at bedtime, at nights 14 through 25. Usually I do 3 cycles and then reassess. If they have elevated estrone, the books say 100. Usually when it starts getting, if it's over 90, I get a little nervous. 7 keto DHEA start at 25. You can go to 100. DIM and the decalcium glucarate will decrease estrogen levels. Berberine for your blood sugar, fish oil for pretty much everything. Quercetin is an anti-inflammatory, and we use that for allergies also. Bromelain. What's next? I don't know what happened here. We got a whole bunch of slides that are blanks. So testosterone control, spironolactone, metformin, that's the medical doctor thing. Cinnamon, vanadium, chromium, biotin is a combination. Cinnamon, vanadium, chromium, and what's the other one? And Gymnea sylvestre, that's that Syndrome X. Berberine, and then they have combinations with that. Vitamin D, C-reactive protein, elevation, is an inflammatory marker, and we use fish oil and turmeric for that. Elevated homocysteine, we use the methylated B vitamins. Just when you're feeling comfortable and think you got everything nailed, here's the North American Menopause Society. These are the people that were behind trying to get rid of bioidentical hormones compounded. And so, they can be inconsistent, and there's no FDA oversight. Well, we what we think about that anymore. Saliva tests are no good. There's no evidence to support the use of DHEA for the management of anything. So those are them. Remember that this was in 2015, 2016, FDA approved Intrarosa, which is a DHEA vaginal insert for dyspareunia. So there's that. Here's a estrogen, just a chart, estrogen deficiency, estrogen excess. You should know all this by now. And in men, down at the bottom right, but that makes it, just kind of succinct. I just threw this in for just, so when I give these talks at AMMG, they tell me just do estrogen, don't mention progesterone, which is almost impossible. So I throw this in just as a balance. Testosterone self-assessment here. So these are, again, deficiency and excess. So testosterone, anxiety, depression, poor sense of self-worth, poor muscle tone, urinary incontinence, vaginal dryness, poor libido. Testosterone is inversely related to, levels are inversely related to glucose levels. It's inversely related to cognitive function and muscle tone. So too much testosterone. Again, the books say aggressiveness. I don't hardly see it at all. I don't know if you do. Oily skin, oily hair, acne, skin breakouts on the neck and shoulders, redness in the face, swelling of the hands and feet, higher blood pressures. Okay. So that's too much testosterone. And that's it. Okay.
Okay.
Okay, so if you want to continue on sort of our female hormone survey next week, I think what we'll do is progesterone.
Great.
Okay, so we'll give you the basics on that, and then we'll also give you the big controversy, progesterone after hysterectomy, yay or nay. Did we do that one already?
Oh, no, that'll be great.
Okay, so okay. What did I say your homework assignment was? Was it K2, adding K2? I forget.
K2, it was
Yeah.
regarding. Yes,
Yeah,
sir.
that's your homework assignment, right?
All right, the importance of K2 with vitamin D3.
Yeah, and I'm gonna send you the link for the hair video.
Yes, yes.
Anything else?
No,
Okay,
no.
I thought there might have been something else, but okay. All right, I'll send you the link for the hair video. And any other questions?
There was there was a file that you sent to me on WeTransfer, sir, that expired. And I think it was the female hormone primer one that expired that I didn't download in time. 'Cause I think we did female primer two. You split it in two parts.
Right. I think it might be on YouTube,
Oh, it
but
is.
I can send it to you again. Okay. Yeah, I can do that. It's
My
if you say please.
please.
All
And
right.
when you stop the recording, I do have a question for you. I was wanting to ask you.
All right, hang on. All right, so that's it.